Our topic for today is about electrocardiography. Regarding the history, Luigi Galvani demonstrated that the direct contact with the electrical generator or ground through an electrical conductor would lead to a muscle contraction in a frog's leg. Next is Rudolf Albert von Kolliker and Heinrich Müller recorded electric currents produced by a frog's heart. Next is Carlo Matteucci, connected the frog's heart to its leg muscle and noticed that it twitched with each heartbeat and led him to conclude that it was the heart that was giving out some kind of electrical signal. Next is Murray. He used the electrometer to record the electrical activity of an exposed frog's heart. William Einthoven developed the elegant, reliable, and sensitive string galvanometer. He was able to record electrical forces of the heart from the hands and feet of the subject without even undressing them. Soon, he was awarded in 1924 Nobel Prize for Physiology or Medicine for his discovery of the electrical properties of the heart through electrocardiograph, which he developed as a practical clinical instrument and an important tool in the diagnosis of heart disease. The American Heart Association and Heart Society of Britain and Ireland published the standards for recording precordial leads in 1938. And then we have Dr. Emanuel Goldberger of Lincoln Hospital, New York, who used the Wilson Central Terminal constructed unipolar leads with central terminal and connected two additional positive unipolar leads on each of the left and right arms and the left leg. During the time of Beethoven, an old string galvanometer electrocardiograph showing the big machine with the patient rinsing his extremities in the cylindrical electrodes filled with electrolyte solution is seen in the picture on your left. The picture on your right is a computer-based ECG. For the introduction, the electrocardiogram, also referred to as the ECG or 12-lead ECG or EKG, is a non-invasive diagnostic test that evaluates the heart's electrical system to assess for heart disease. This uses flat metal electrodes placed on the chest to detect electrical charges generated by the heart as it beats. And then, later it would then be graphed. The doctor can analyze the patterns to get better understanding of the heart rate and heart rhythm to identify some types of structural heart disease and evaluate cardiac efficiency. Beethoven named the waveforms produced by the heart's electrical system as P, Q, R, S, and T. The contraction of any muscle is associated with electrical changes called depolarization, and these changes can be detected by electrodes attached to the surface of the body. The wave pattern should have a consistent shape. If your waves are not consistent or if they do not appear as standard waves, this is indicative of heart disease. The normal pacemaker site of the heart is the SA node. The conductivity of the heart normally follows an electrical pathway from SA node through the interatrial pathway to the AV node to the bundle of His, down the bundle branches to the Purkinje fibers. So why do we have to perform ECG? There are a number of conditions that can be detected when the doctor checks the pulse, such as tachycardia or the rapid heart rate, bradycardia or the slow heart rate, and arrhythmia, which is the irregular heart rate. ECG wave patterns not only verify these alterations in heart rhythm, certain changes in the shape of the waves provide information about the specific type of heart disease and which region in the heart is affected. To continue, an ECG may also be recommended if the patient has signs or symptoms of heart disease, such as chest pain, shortness of breath, lightheadedness, dizziness, or fainting. Likewise, if the patient has signs of stroke, such as vision changes, numbness, weakness, or communication problems. The patient would also likely to be needing an ECG because some types of heart disease can cause a stroke. So these are the indications of ECG. First would be heart arrhythmias. Example, premature ventricular complexes. Next would be conduction abnormalities that may result from issues regarding how the electrical impulses spread across the heart. Next, signs of ongoing or prior myocardial infarction or heart attack. Signs of severe coronary artery disease. If the heart muscle has become abnormally thickened, as in hypertrophic cardiomyopathy. Signs of congenital electrical abnormalities. Electrolyte imbalances, particularly elevated or decreased levels of potassium, calcium, or magnesium. Congenital heart defects, and infections involving the heart, such as pericarditis, which is an infection of the protective tissue surrounding the heart. There are no medical conditions associated with an increased risk or adverse side effects from ECG. Therefore, the test is safe to perform. For the examination protocol before examination, once the doctor is worried that the patient has especially rapid heart rhythm, the patient may be asked to abstain from caffeine for 6 to 10 hours before the test. During the test, the technologist must first explain the procedure and reassure the patient that the procedure is absolutely safe. You may also ask the patient to change into a hospital gown and lay down on an examination table. After that, the electrodes are placed on each arm and leg and 6 on the chest. Each electrode is a flat coin-shaped plate with wires attached to the ECG machine, which looks like a computer. The electrodes detect electrical activity produced by the heart and transmit this information to the machine, where it is processed and saved electronically or printed out as an ECG tracing. Readings will be taken for about 5 minutes. During this time, the patient will be asked to remain still as movement can disrupt the pattern. There is no pain or discomfort associated with the test. So after the test, the electrodes are removed. If there is any sticky material remaining, it can be easily wiped off with an alcohol pad. The patient may also experience some pulling of hair underneath the nose, but generally, the technologies must be very careful while taking them off. The patient should not expect for any side effects after an ECG. Responsibilities of ECG technicians or technologists. The technicians should remind the patients to lie flat and relax as possible because any movements or muscular twitchings recorded by the machine may alter the tracing. Remind the patient also not to wear jewelries or metal during ECG. If unavoidable, care should be taken that the leads should not come in contact with the metal. Check the machine for proper standardization. When the standardization button is pressed, there should be a deflection of 10 mm on the graph. A spike made will be of 2 large squares. Check if the machine is properly grounded to prevent interference with the recording. And finally, the technicians should ensure correct placement of leads while taking the ECG. The improper placement of the chest leads can greatly distort the tracing and alter the diagnosis. ECG equipment includes ECG machine, electrodes, paper, and connecting wires. These are the ECG electrodes that are applied on patients' chest and extremities. The lead wires or cable connections have clip or snap forms. The ECG paper consists of vertical and horizontal lines. This measures the voltage in millivolts. Each small box is equal to 0.04 seconds of time, and each large box is equal to 0.20 seconds of time. Next is the lead system. The ECG recorder compares the electrical activity detected in different electrodes. An electrical picture obtained is called lead. For example, when the recorder is set to lead 1, it is comparing the electrical events detected by the electrodes attached to right and left arm. The 12-lead ECG consists of first, the 6-limbed leads. The components are the 3 bipolar limb leads and the 3 unipolar augmented leads. This can be obtained through the 4 electrodes placed on the right arm, right leg, left arm, and left leg. Next would be the 6 chest leads. The correct placement of the electrodes would be very important in the interpretation of the readings. So this consists of V1. The position of the electrode is in the 4th intercostal space or ICS found in the right sternal border. On the opposite side, at the left sternal border, is the V2. V3 is the one placed midway between V2 and V4. V4 is placed on the 5th ICS in the left mid-clavicular line. V5 is the same level as V4, found anteriorly at the axillary line. And finally, the V6 is positioned at the same level as V4 and V5 in the mid-axillary line. So this picture would show the positioning of the V1 to V6 electrodes that comprise the 6 chest leads. And then this picture would show the correct positioning of the electrodes that comprise part of the 6 limb leads. So this is an anatomical picture that would show where V1 to V6 are placed on the chest. This will show the normal ECG morphology, wherein the electrical activity of the cardiac cycle is characterized by 5 primary wave deflections designated by letters P, Q, R, S, and T. The P wave represents atrial contraction. The shape of the P wave remains the same unless it is generated from a different focus. For the QRS complex, the Q wave is the first negative deflection. R wave is the first positive deflection after the P wave. S wave is the negative deflection following R wave, and it is about 0.08 to 0.12 seconds, represented by 3 small squares. The PR interval is the time that it takes for the impulse to spread from atria to ventricles. The ST segment represents the ventricular repolarization. Normally, it is not elevated, which is about 1 millimeter. The T wave is the ventricular repolarization, usually positive, rounded, and slightly asymmetric. The U wave results from slow repolarization of ventricular Purkinje fibers. It is more common in lead V3. And finally is the QT interval, which is the total time required for ventricular depolarization and repolarization. A prolonged QT interval may lead to ventricular tachycardia.